Okay, so welcome everybody to this webinar of the European Childhood Obesity Group on the prevention of adult diseases in childhood. We are here today with three panelists and a host, Dénes Molnár, Professor Emeritus at the Department of Pediatrics at Medical School University of Pécs, who will be in a second giving you a welcoming introduction. This webinar is recorded and will be made available together with the slides on the website of ECOG. A Q&A is foreseen at the end of every presentation and at the end of this webinar. If you'd like to ask a question, please write it down by using the Q&A tool and mention clearly to whom your question is directed to. With us, we have three panelists, Professor Tibor, Ertl, Sarolta, Stomfai, and Assistant Professor Malgorzata, Wojcik, who will be giving three presentations. So we are starting with a presentation on early programming with special focus on in vitro fertilization. Then following, we have Sarolta's presentation on screening of risk groups, and we are finishing with Malgorzata's presentation on hypertension in children, to treat or not to treat. Dénes, I'm giving you the floor. Please, you can take over.
Yes, I share my screen. Is it visible now? So, yes. First of all, I would like to welcome everybody, all participants on behalf of ECOG, European Childhood Obesity Group. And I thank the keynote lecturers, the panelists, Professor Tibor Ertl and Sarolta Stomfai, and the lady coming from Krakow, from Poland as well. So it is an international meeting, and we deal with a very difficult question, prevention of adult diseases in childhood. Prevention itself is doesn't want to work, as I see as the second one. So why is this topic is important and has a growing importance? Because the cardiovascular diseases, cancer, so-called non-communicating diseases, are the leading causes of death all over the world. So it's a global problem. And this slide shows the projection of the data until 2030. And you can see that cancers will be the leading cause, following by ischemic heart disease and cerebrovascular disease. But the so-called cardiovascular disease, ischemic heart and cerebrovascular diseases are still ahead of cancers. The latest data coming from WHO says that 71% of global deaths are caused by NCDs. It's a huge number, 41 million people per year. And a large number of these deaths are premature deaths. Means that people between the age of 30 and 69 dies prematurely caused by NCDs. And the leading cause is cardiovascular disease, followed by cancers, respiratory disease, and diabetes in the world. So the prevention of these diseases, at least to decrease the risk of developing this kind of diseases, has major significance. And pediatrics has a new ambition to prevent adult NCDs in childhood and bring up a mentally and physically healthier new generation. And obviously, this webinar cannot cover all aspects of this multifaceted topic. We targeted 3 elements of prevention, and these 3 elements and lectures were already introduced by Milena, our host. So the first lecture is on early programming, the first 1000 days, with a special focus on in vitro fertilization. Since the first in vitro fertilization in 1978, more than 9 million IVF babies have been born. And the second lecture is screening of risk groups, which is a very difficult task, as you will see, and hypertension, which is a major problem, especially during the age of adolescence. So now I ask Professor Tibor Ertl to present his lecture.
Okay, Dénes, thank you very much for the kind invitation and the kind introduction. And I would like to share my slides. Do you see my slides?
Yes, it's okay.
Okay. Again, thank you very much. And all the co-authors who are listed here are members of the National Laboratory on Human Reproduction. And we are very much interested on the long-term effects on in vitro fertilization. We are working at the University of Pécs, Department of Pediatrics, Obstetrics, Gynecology, and Neonatology. As a young fellow in 1978, during the summer, I was called every second day. And in a sunny Sunday afternoon, I picked up the Lancet and I found a very interesting letter. It was just a simple letter. And the title was Birth After the Reimplantation of a Human Embryo, written by Steptoe and Edwards. And they also declared, we hope to publish further medical and scientific details in your columns at later date. Since then, Louise Brown gave a birth to a healthy child in 2006. And, you know, Dénes gave the answer to my first question, how many babies have been born since Louise Brown in 1978? And the other important question is, does the mode of conception influence the intrauterine development of the fetus?
I am launching the question. We will wait for everyone to answer, and then I will share the results. So let's start with question 1. How many babies have been born from IVF around the world since Louise Brown's birth?
Milena, I cannot answer, I cannot tick.
Because you are not allowed to answer.
You are panelist, Dénes. Okay. So I will share the results of the first question. If you wish to comment on this one already, Tibor.
Yeah, thank you very much. For sure, more than 5 million, but according to the latest data, around 9 million. But that seems to be perfect.
Okay, and I will launch the second question now. So, does the mode of conception influence the intrauterine development of the fetus? Yes or no? Okay, I will share the results again.
Yes, 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 this is the correct answer. Or maybe probably would be better, because I have to emphasize most of the babies conceived using artificial techniques are healthy, luckily. Can I go on with my presentation?
Yes, of course. Please go ahead.
Okay. As I mentioned earlier, we belong to the national group of investigating the effect of assisted reproduction, and we are interested very much in transgenerational effects of the IVF. And since 1978, several papers were published dealing with the IVF and the consequences, and most of the IVF children are healthy, luckily, but IVF has also been associated with adverse events and adverse obstetric and perinatal outcomes, as well as congenital abnormalities. And, sorry, also, infertility itself may be an independent risk factor, but animal models suggest that epigenetic changes in genes involved in growth and development are involved also during this process. Also, there are some data suggesting an association between IVF and neurodevelopmental disorders, as well as potentially long-term metabolic outcomes. The first baby in Hungary, first IVF baby, was born at our department. Therefore, it's absolutely obvious that we are interested following the babies, and we analyzed the cohort of more than 15,000 neonates born from January 1999 till the end of December 2008. And we examined the association between the artificial techniques and developmental abnormalities in male genital tract, such hypospadias or cryptorchidism, after controlling for potential confounding factors such as low birth weight, prematurity, and twinning. In conclusion, we found that IVF and ICSI, by increasing the risk of prematurity, low birth weight, and multiple gestation, indirect risk factors for developing male genital malformations. Infants with normal birth weight born from singleton pregnancies, ICSI is a specific risk factor for hypospadias.
Tibor, could you explain ICSI?
Yeah, intracytoplasmatic sperm injection. It is the abbreviation of the ICSI. And in the first table, we just summarized what we found. Not surprisingly, the gestational age and the birth weight were lower compared to the control group, and the rate of prematurity also considerably higher compared to the naturally conceived infants. The twinning is also characteristic, close to 50% of the total number of babies. And in this period, we have about 5.9% of the total number of deliveries as a IVF or ICSI baby. Finally, the table 2 shows the occurrence of the male reproductive tract abnormalities. I would like to draw your attention to the ICSI group, where the hypospadias and cryptorchidism was significantly higher compared to the normally conceived newborn infants. We have several comments on this article, and the most important quote: the risk for the development of testicular cancer in patients with cryptorchidism and hypospadias was recently calculated as 2.1 up to 3.7, which is surprisingly high number. This is a problem, and Nature dealt with this problem in 2018, and they stated that there is an increasing evidence which suggests that the children born through ICSI have an increased risk of congenital malformations, chromosomal abnormalities, childhood cancer, and disrupted reproductive hormonal profile compared to the naturally conceived children. Moreover, epigenetic disorders and impaired neurodevelopment have been observed in infants born using ICSI compared to naturally conceived children. The underlying parental infertility seems to have a major effect on the health of ICSI offspring. However, some of these health issues might be related with the art process itself as a whole, or ICSI in particular. Our team in the IVF group made an attempt to reduce the potential harmful effects of light on blastocyst development during IVF process, and they implemented a new method in 2017. They are avoiding light and they are working under the red light. And as a result, you can see first very, very important fact. The mean total manipulation time was 1,556 seconds during IVF, and more than the double, 3,227 seconds during the ICSI procedure. And this light protected group had a higher success rate with regard to ICSI fertilization, and the number of clinical pregnancies was significantly higher compared to the control group. The incidence of male reproductive disorders, including hypospadias, cryptorchidism, and testicular cancer, has increased in recent years. It is supposed that these reproductive disorders may be symptoms from one underlying entity, the so-called testicular dysgenesis syndrome. A disturbed hormonal milieu during early fetal life may be responsible for the increasing risk of disorders in the male reproductive organs. Two symptoms for sure, hypospadias and cryptorchidism, are fetal origin. And recent evidence also suggests that testis cancer is also of developmental origin. And in Europe, in a lot of countries, the rate of IVF babies is about 8%. And in addition, lower sperm count, smaller testis size, lower serum levels of testosterone are seen in adult men whose mothers receive fertility treatment. A leading expert in this field is Kakabek, who published an important article in 2016 dealing with male reproductive disorders and fertility trends. Cryptorchidism is one of the most common birth defects, affecting 2 up to 9% of boys born full-term. Cryptorchidism is a risk factor for testicular cancer, hypospadias also, and the incidence really steadily increased, because in 1950s it was about 2.7%, and in the early 2000 it is already 5%, but some data suggested as high number as 9%. The hypothesis of testicular dysgenesis syndrome is shown in this cartoon. And you can see the developing Sertoli and Leydig cells and germ cells, environmental exposure, genetic defects and polymorphisms. Lifestyle factors, epigenetic factors may influence. In the case of decreased Leydig cell function, you can see that the cryptorchidism may develop. and the testosterone synthesis is decreased, and that could be one of the reasons of hypospadias, and later on during the adulthood also decreased testosterone production was if the Sertoli cell function is disturbed, it may result in testicular cancer. This slide shows basically the same. The upper part is the normal pathway, normal development, and the lower part shows the impaired development and the possible end result seminal. This study also investigated the incidence of hypospadias and summarized the data of a couple of studies coming from USA, Korea, Finland, Netherlands, Denmark, and the incidence is about 1%, but you can see in some countries less than 1.3. Very important to recognize that the number of the women aged between 25 and 40 is steadily decreasing. And the number of the artificial techniques steadily increasing, and the blue part of the column represents the ICSI, and the brown represents the IVF. Being small for gestational age is a risk factor for both cryptorchidism and hypospadias. Some epigenetic modifications present in sperm are being transferred to the embryo, and transgenerational effects of some environmental exposures or lifestyle habits have been observed in humans. This slide shows that the mean ages of women delivering is steadily increasing since 1970. And this is another important number, the fertility rate. Most of the European countries, the fertility rate is about 1.5. In Hungary, for sure, we have this value 1.5. If it remains by the third generation, the population will drop dramatically down to the 40% of the present population. Therefore, we have to do something against it. David Barker, an English epidemiologist, proposed that adverse nutrition in early life, including prenatally as measured by low birth weight, increased susceptibility to the metabolic syndrome, which includes obesity, diabetes, hypertension, hyperlipidemia, and complications that include coronary heart disease and stroke. The rapid postnatal growth is also a risk factor. But the cause of the metabolic syndrome is likely to be multifactorial, and transgenerational epigenetic inheritance is a possible. Nutrition is also important, and the microbiota also, and health before and during pregnancy and mode of delivery could influence the child's microbiota, introducing further potential avenues to improve the prevention. Being small for gestational age, probably a little bit risky with regard to the developing high blood pressure, metabolic syndrome type 2 diabetes mellitus and cardiovascular disease during adulthood. And large for gestational age situation also increases the risk of obesity and metabolic syndrome in the postnatal stage. What do you think? Does IVF have any effect on the cardiovascular and metabolic risk of the offsprings? The question is yes. There is a study systematic review and meta-analysis dealing with this problem. And 19 studies were included for analysis, and more than 2,100 IVF babies were compared to more than 4,000 naturally conceived offsprings, ranging from childhood to early adulthood. And the blood pressure levels of IVF ICSI offspring were significantly higher. Cardiac diastolic function was suboptimal, and vessel thickness was higher among IVF ICSI offspring. However, the BMI was the same, but lower low-density lipoprotein cholesterol levels and higher fasting insulin levels were detected. I will show a couple of slides emphasizing blood pressure, systolic and diastolic. BMI is the same. Fasting insulin is higher, and you can see the result of the cholesterol, the different subtypes and the triglycerides. Last year in the human reproduction, an interesting question was addressed. Do assisted reproductive technologies and in vitro embryo culture influence the epigenetic control of imprinted genes and transposable elements in children? And to cut the long story short, the answer is yes. Significant differences in the DNA methylation in imprinting genes or transposon families were reported between ART and naturally conceived children, but there was no difference between culture media. Another important systemic review proved that imprinting disorders such as Prader-Willi or Silver-Russell or Beckwith-Wiedemann syndrome, as well as Albright syndrome, are relatively most common among children whose mother received artificial treatment. Close to the end of my presentation, I would like to summarize the effects which may influence the health and imprinting, maternal stress situation, assisted reproductive technologies, and chemical disruptors. Dealing with the assisted reproductive technologies, altered metabolic programming could be observed. Imprinted gene defects in the placenta were also detected. Altered gene methylation in cord blood also proved, and birth defects are more common in certain situations. Moreover, they have higher preterm rate, therefore fast catch-up growth is common, and lack of breast milk is also more frequent among mothers who gave birth to preterm infant. Altogether, that means there is an increased risk of chronic disease in adulthood. In summary, I would like to emphasize that cardiovascular and metabolic, growth and pubertal development, endocrine abnormalities could be present more frequently, like subclinical hypothyroidism, or in the girls, premature activation of the adrenal gland, or fat deposition, diastolic and systolic blood pressure elevation, and elevated fasting glucose level. At the end of my presentation, thank you for your attention, but I have to emphasize that most IVF conceived children are healthy, and our laboratory is working with the support of the National Laboratories Program. Thank you very much for your attention.
Tibor, thank you very much for this nice and quite exhaustive lecture. You covered a lot of topics concerning in vitro fertilization and its long-term effects. I don't know whether we ask questions right now or after the 3 lectures. What is the opinion of Milena?
We can have a few questions right now on this presentation, if there are any. I am not seeing any on the chat nor in the Q&A sessions. I don't know if any of the panelists have a comment they want to share on this presentation as well. And if we are not getting questions, then we can just simply move on.
Yeah. So I ask the audience whether they have questions or not. In the meantime, I would like to ask Tibor whether there are data that in vitro fertilization itself leads to later obesity. Since this is an ECOG webinar, I saw that yes, it might increase the fat deposition.
Yes, it might increase, but taking together all the available data, the BMI is the same in naturally conceived and artificially conceived young adults.
Yeah, maybe that the low birth weight can be another cause of the disadvantageous effects of in vitro fertilization. So not the process itself, but the increased risk of prematurity.
Yes, but if you clean the data and if you will compare the term singleton babies in 2 groups, one of them naturally conceived and the other one is IVF or ECOG babies, there are certain risks which are more common using IVF fertilization.
Okay. I don't see whether
there are no questions so far. No, there are no questions so far, Dénes, so I think we can move to the next presentation and hold the question on this presentation for the end.
Okay, so Tibor, thank you very much for this excellent lecture.
Thank you.
We continue with the second lecture, Sarolta Stomfai, screening of risk groups.
Okay, hi everybody. I'm Sarolta Stomfai from Hungary, from University of Pécs, from the pediatrician clinic. And I would like to talk about cardiovascular risk estimating in childhood. Sorry, 1 second.
General, put your video on.
Oh yes, of course.
We're not seeing it. Thank you. Perfect. Thank you.
Welcome. Okay. Generally, the global prevalence of overweight and obesity in children and adolescents has increased significantly over the past several decades. Since 1975, worldwide obesity has nearly tripled. And we can declare that nearly 40 million children are overweight or obese under the age of 5. Over 340 million children and adolescents aged between 5 and 19 are overweight or obese. But never forget, obesity is preventable. The World Health Organization analysis reveals the countries in Europe where childhood obesity is most prevalent revealing the problem to be most pronounced in Mediterranean nations. Regardless of gender, Cyprus has the largest share of obese between 6 to 9 years old. For boys, Cyprus is joined by Italy, and in third place is Greece. And for European girls, Spain has the second highest rate, followed by Malta. We have a lot of data from large prospective pediatric cardiovascular epidemiological studies, like one of the biggest studies, the Bogalusa heart study, about we heard before for sure, and another one is pathobiological determinants of atherosclerosis in youth, which are demonstrating that coronary heart disease, ischemic stroke, and peripheral artery disease has its roots already in childhood and progresses to measurable vascular changes in young adulthood. Childhood obesity, nearly all organs are affected by obesity-related diseases. We can see and we know that neurological, endocrine, renal, gastrointestinal, pulmonary, musculoskeletal, psychosocial, and last but not least, the cardiovascular system, about I'm going to talk detailed. The always circulating question is, what is the definition of metabolic syndrome? The diagnostic criteria of the metabolic syndrome have been applied in several studies in obese adults to assess the metabolic risk associated with obesity. In the past, 3 definitions have been proposed in adults. One of them is the World Health Organization definition. Another one is the National Cholesterol Education Program Adult Treatment Panel. And the last one, the European Group for the Study of Insulin Resistance, or International Diabetes Federation. Nevertheless, these definitions have been used in several studies implemented in children populations, which reported a high prevalence of the metabolic syndrome in obese children and adolescents. We also have these reliable charts for cardiovascular risk assessment in the case of adults for primary care. But the most, but what about children? The most frequently mentioned components of metabolic syndrome are obesity, hypertension, dyslipidemia, and hyperinsulinemia, or impaired glucose tolerance. However, in case of children, we don't even know what group of children are at risk. There is no reliable, standardized, evidence-based tool for predicting cardiovascular disease in adulthood. And we can't identify those who should be screened for metabolic alterations like dyslipidemia, insulin resistance, impaired glucose homeostasis, and so on. There is a significant difference that adult cutoffs don't meet children's thresholds. Finally, different risk factors enhance each other. Therefore, we need to take account of most aspects. Brambilla proposed a comprehensive approach for children and adolescents, which called Miracle. It means that metabolic individual risk factor and clustering estimation in children. The overall evaluation of the risk was based on the combination of individual, like body weight, waist to weight ratio, blood pressure, birth weight, duration of breastfeeding, and family history like cardiovascular disease, type 2 diabetes, hypertension, and dyslipidemia. This cardiovascular risk estimation tool could be easily applied in primary care circumstances, but has never been validated and was tested only in a small group of obese children. This slide shows those attempts had strong enough evidence for a clear definition, detailed of family history, individual history, clinical features, and metabolic abnormalities. What was our purpose? We would like to introduce and validate a non-invasive cardiovascular risk estimating tool similar to the above mentioned Miracle, in the IDFIX population, referring to prepubertal children, and to evaluate how the family, anamnestic, and individual risk factors predict the presence of metabolic risk factors, means laboratory values. IDFIX was the identification and prevention of dietary and lifestyle-induced health effects in children and infants. It is a population-based multi-center study which included children age from 2 to 10 years from 8 European countries, examined more than 16,000 participants. We examined nearly 6,000 children who had all anamnestic and laboratory parameters we needed. This slide introduces the most important characteristic of the subjects are shown, and the population was well balanced, referring to gender. The mean age was 6.3, and you can see the most important data about weight, height, BMI, and waist circumferences. This slide introduced the individual parameters. On the one hand, anthropometric data like BMI values categorized overweight or obese based on the International Obesity Task Force. You can see waist to height ratio based on 90th percentiles of IDFIX study. And on the other hand, anamnestical data like gestational weight or duration of breastfeeding. Blood pressure values were categorized based also on IDFIX data population. In family history included hypertension, type 2 diabetes, cardiovascular disease, and dyslipidemia in case of mother or father or sibling or any of grandparents. As a next step, we investigated the individual and family factors with cardiometabolic markers. Like you can read here that fasting glucose, total cholesterol, high density lipoprotein, triglyceride, hemoglobin A1C, HOMA index, and C-reactive protein. And we use the categorization like these laboratory parameters were categorized by using the age and the gender-specific 90th percentile values of the IDFIX population as cutoff points, except, of course, HDL cholesterol, where the 10th percentile value or lower was considered pathological. On this slide, we would like to demonstrate of normal and abnormal laboratory results. In a normal prepubertal children population, about 90% the children has normal and about 10% the pathological laboratory values, any of the above listed parameters. It also shows that in normal prepubertal population, wide screening can't be recommended since only 10% of this population produced pathological laboratory values. We have further investigated the number of abnormal laboratory parameters in different age categories. You can see this in this figure. In most age categories, 50% of children had no abnormal laboratory values. What were the effects of individual parameters? On this slide, you can see that normal BMI and normal waist to height ratio are protective, while increased BMI, especially above 30, and elevated waist to height ratio increase the odds ratios significantly. This slide shows that high blood pressure and especially low birth weight increase the risk of abnormal laboratory values. And on the last one related to individual parameters, short duration of breastfeeding are also raise the risk of pathological lab values. What about effects of family parameters? We can declare that positive family history also clearly increases the chance for of pathological laboratory values. This figure demonstrates that children having less than 3 abnormal input variables have a better chance to provide normal laboratory values than children with more than 4 abnormal laboratory parameters. It's clearly demonstrated on this slide that that 0 or 1 risk parameter is protective against having abnormal laboratory values. In case of 3 abnormal input variables, we cannot confidently conclude the risk, although there is a clear tendency. On this slide, Logot ratio values are shown on this slide for different individual risk factors. BMI over 30 and waist to height ratio increases the chance for elevated HOMA index and triglyceride levels. And low birth weight influences only triglyceride level. Here is low birth weight. Normal breastfeeding is protective factor, while short duration of breastfeeding slightly increases the risk of high cholesterol. Globally, there is a clear relationship between the individual parameters, mostly anthropometric factors, and pathological cardiometabolic laboratory profiles. The next slide introduces the relationship between the family risk factors and laboratory parameters. Relationship here is much weaker, and hypertension in the family history mildly but significant influence the risk of laboratory parameters. And diabetes in the family history increases chance of having elevated glucose and HOMA index levels. Summarizing our results, 10% of laboratory results can be expected to be pathological in prepubertal children. It's very important that having more than 4 pathological means summarized individual and anamnestical parameters, mean getting more pathological cardiometabolic laboratory values. Family parameters aren't so influential, but they also contribute to the final results. And our results suggest that the individual and family risk factors may herald the presence of positive laboratory results. Finally, each individual and family risk factors had its own predictive spectrum. We can conclude that the present study suggests that the investigated non-invasive method could be useful in primary pediatric practice in order to identify those young children where laboratory checking could be indicated. And using this tool, the risk status can be verified in time, giving chance for reversing it by successful early intervention. This last slide demonstrates that early intervention is much more effective, but later produces only has a small reduction. Our take-home message is very short, early prevention, but we have to see about what we have to hear and to talk. Thank you for your attention. And should I read my questions?
Yes, we can have questions if you'd like.
Yeah, my first question is that the easiest way to involve children for metabolic risk screening after the following, except.
So we have 5 possible answers. The poll is open and I will wait just a second to see the answers
are anthropometric measurements, blood pressure measurement, individual history, blood sampling, or family history taking.
Okay, so I'm going to share the results.
Yes, of course, blood sampling was the good answer, of course, because we talk about children. So, okay, thank you. The next question was, I think it's easy. Do we have consensus about the definition of metabolic syndrome in childhood? Yes or no?
It seems to be an easy question indeed, because so far everyone agrees.
I hope.
We have some movement. Okay, I'm going to share the results.
Oh, okay, thank you. Of course, it was no. And the last question was, how many % of the laboratory results can be expected to be pathological in prepubertal children? 10%, 20%, or 30%?
Okay, we have a tight one on this one.
It was 10%. We could hear it in the presentation, but okay. So thank you.
Sarolta, thank you very much for the presentation. And now I ask the audience whether they have any questions. If you want, you can ask questions concerning this non-invasive screening method.
So far, we don't have any question, Dénes. So
okay. So, but as we see from this presentation, in a normal population, this method can work, but further tests are necessary in real life with the help of pediatric GPs in young population, and it could demonstrate whether this method, this tool, works in everyday life or not. So, Sarolta, thank you very much for the presentation. And then we can go on. And I ask Malgorzata Wojcik from Krakow to present her presentation lecture on hypertension.
Thank you very much. Thank you, Dénes. Thank you, Daniel, for inviting me to this excellent meeting. And the first time I saw the topic which you sent to me, I thought it seems to be a little bit trivial. But after a reflection, let me share my reflection. I thought that in everyday clinical practice, the answer to this question is not always obvious for me, and I believe it's also not obvious for pediatricians dealing with children with obesity and hypertension. I am a pediatric endocrinologist and pediatrician working in Krakow. I'm also ECOG member, but today, Okay, next slide. I also represent a group of people, a group of healthcare professionals and scientists working together in HyperChild network. This is a multidisciplinary international team focused on acquiring a holistic understanding of the factors affecting hypertension in children. We try to work together in order to propose and implement corrective and preventive actions in our countries and in the whole Europe and whole world. Let me start with a question. I want to ask you, what do you think? How often do we diagnose arterial hypertension in pediatric population? Milena, can I ask for the question? Okay, thank you. Is it below 1%, 2 to 4, 5 to 10, or 10 to 30? What do you think? Okay. We see the results. The answer to this question is not very easy. The most of the literature points to number 2 to 4. For Hungary, for example, I found the prevalence at the level of 2.5% of general pediatric population. But I will try to show you that the answer to this question is not very easy. In the past, the childhood hypertension was considered as a rare disease. The first guidelines regarding the diagnosis and treatment were published about 40 years ago, but the highest interest of this problem was noticed after 2004, after publication of the document called Fourth Report on the Diagnosis, Evaluation and Treatment of High Blood Pressure in Children and Adolescents, briefly called the Fourth Report, which is still the base for our guidelines. And since then, a lot of research has been created, a lot of scientific papers and textbooks have been published, and all of them describe a rapid change of the epidemiology, etiology, and treatment models of pediatric hypertension. Look, in the past, arterial hypertension in children was usually related to underlying conditions like, for example, kidney disorders. Nowadays, the face of pediatric hypertension is changing, and most of the cases are primary hypertension related to increased prevalence of obesity. In 2019, a nice meta-analysis and literature review was published after reviewing more than 9,000 records identified in the most popular scientific databases. They choose 47 full-text papers, and that papers were carefully analyzed and reviewed. They found that arterial hypertension was diagnosed in 4% of all participants. But if we look to the sub-analysis and take into consideration BMI, we can notice that arterial hypertension was present in about 5% of participants, and in the group of obese patients, it was 3 times more. That is what scientific studies say, but unfortunately, when we go to our offices, to our daily practice, we must be aware that most of the cases of childhood hypertension are still undiagnosed. We may ask the question why, and the reasons are much more complicated than it seems. The first cause is, of course, not fully symptomatic presentation of hypertension. Hypertension does not hurt. Of course, we have some difficulties with challenging assessments. It's difficult to measure the blood pressure in an appropriate way. And what more, we have some confusions regarding to the normal values. For example, the biggest problem is two different models of guidelines on the both sides of Atlantic Ocean. And the greatest concern is with children between 13 and 16 who were subjected to two completely different treatment and diagnostic groups. That may be confusion for clinician. Another problem is the problem of communication between doctors, between healthcare professionals, and between parents. Let me share you the reflections from a nice study released last year. It was a study based on parents' opinion, parents of children with diagnosed hypertension. They said it was elevated, but they didn't really seem concerned about it at the time. They just gave me some handouts about it, and then that's pretty much all they really said about it. There wasn't any solution given. How to bring it down, or if there is any kind of medication that would help, or diet change, or anything like that. That's really sad. And if we look at the changing phase of pediatric hypertension in the era of childhood obesity epidemic, we will see that most of the cases of primary hypertension are now seen than it was in the past. And maybe you ask yourself, and I also asked myself, why pediatric endocrinologist is talking to ECOG members about hypertension. And the answer is in epidemiology. If you look at this cartoon, you will clearly see that year by year, this is quite recently published data, new cases of primary hypertension are diagnosed in endocrine office. This risk of hypertension appears to increase with the obesity and obesity severity. There is a 4-fold increase in blood pressure value among children with severe obesity, about 99th percentile, and 2-fold increase in children with BMI about 95th percentile when we compare to the normal weight children and adolescents. When we look at the frequency of elevated blood pressure, we clearly see that this percentage increases together with increase of BMI. The association between BMI and blood pressure value has been well documented. And as it was shown in this nice study, look at the number of participants, it's quite impressive as for pediatric study. You may see the association between BMI, between blood pressure for both genders and also for children with normal weight and obesity. The increase of overweight and obesity observed in the last decades and subsequent increase of pediatric hypertension prevalence must be recognized as the major issues of the public health challenge. And you can check data for your own countries as well. I would like to share data from my country, from COSY study. It's shocking. We have a lot of children, prepubertal children with elevated blood pressure, and the association between overweight and obesity in these children is quite clear. So it was quite nicely proved in the past that increase of BMI, even of 1 unit, is associated with increase of blood pressure and risk of hypertension. This relationship is clearly seen in prepubertal children and also in adolescents. Adolescents with obesity are at significantly higher risk of development of hypertension in comparison to healthy peers. It is estimated that approximately 40% of all cases of hypertension during childhood are consequences of excessive body weight. And when we compare with normal children, the relative risk is quite big and we cannot ignore it. If we want to answer why, we have to go step back and look to pathogenesis of the development of arterial hypertension. It's quite complex and many details up to date remain under investigated. According to the current knowledge, 5 main causative factors can be distinguished. The first, metabolic, elevated level of insulin and elevated level of leptin. Both directly may affect the function of sympathetic nervous system. The second and third, of course, associated with hyperinsulinemia as well, lead to renal structure damage and activation of renin-angiotensin system. As an effect, we have abnormal retention of sodium and liquid. The last two are associated with the direct damage of blood vessels and endothelial dysfunction. Both lead to thrombotic state. If we look into details of this process, we obviously see that all this mechanism has in base fat tissue excess and abnormal metabolism of leptin and insulin, which are clearly associated with obesity. So I believe that now you understand that treatment of hypertension in children with obesity will never be successful if we don't treat obesity and its complications itself. But why should we treat arterial hypertension in children? We have several reasons. Hypertension is a well-documented risk factor for cardiovascular diseases in adults, and it affects approximately 25% of young adults nowadays. It is estimated that its contribution to comorbidity is very huge, and it's estimated that arterial hypertension in adolescence is responsible for at least 30% of all deaths in young adults. Can we do anything? Yes, of course. We have a very nice proofs that when we treat arterial hypertension in adolescence, we can decrease the risk of arterial hypertension in later life. There is a quite nice correlation between lifestyle change during adolescence and childhood. The more of successful changes have been made in young people, the fewer cases of arterial hypertension in adults were observed. When we look closely to the population of pediatric patients with primary hypertension, we must not ignore that hypertension is not an isolated complication of obesity. This study recently published clearly shows that obesity and blood pressure, high blood pressure, are usually associated with a cluster of cardiovascular risk factors. All of them are associated with abnormal fat tissue deposits and its activity. And let's go back to the Bogalusa-Hertz study, which was noticed today. It's a quite old study, but the results are still shocking. They show that cardiovascular disease, that atherosclerosis, is not a disease of adult people only. In this picture, you may see that atherosclerosis lesions were found in small children, even prepubertal. What more, the researchers found that the presentation of these cardiovascular risk factors of these morphotic lesions were closely correlated with the value of body mass index and the value of blood pressure. The newest studies show that hypertension during adolescence is a very important risk factor for cardiovascular disorders in young adults. Look at this, it's even more important than smoking. So it's very important to diagnose arterial hypertension in children. But if we look to the pediatric studies, we may notice that some end organ damage will not wait until adulthood. Even in children, 30 to 40% of patients with pediatric hypertension present end organ damage, like, for example, left ventricular hypertrophy. What can we do? There is a nice and sunny point in recently published studies. If we diagnose the patients in an appropriate way, and if we start the intervention on time, we can have a success. This nice study shows how works the intervention, 20 months of intervention in children with primary hypertension. Look at this. Almost half of the participants didn't use any drug, but after 1 year of successful intervention implementation, not only the body mass, the BMI, and blood pressure values improved, but also there was a significant improvement regarding to cardiovascular risk and to end organ damage. So now let me ask you the second question. Shall we treat or not pediatric hypertension?
Question is coming.
Thank you, Milena. I wonder what is your opinion now?
Okay, I'm going to share the results.
Thank you very much. I still have some people to educate. In my opinion, I agree with most of you. We have to treat pediatric hypertension. And what is the most important is to start the treatment of obesity. Treating obesity with the reduction of the fat tissue, with the reduction of the inflammatory state, we can improve the blood pressure values, and we can also improve the whole general metabolic condition. And according to the European guidelines for childhood hypertension, I totally agree, especially in children with primary hypertension induced by obesity. The first line treatment should be lifestyle intervention based on diet and lifestyle modification. But we all know from our daily practice that it's not always successful. In the case when it's not enough and we don't see the benefits of the lifestyle modification, we must not delay the introduction of pharmacological treatment. The danger of the end organ damage and development of the hypertension in young adulthood is very, very serious. So there is no time to waste. We have a lot of drugs that may be used in children. As pediatrician, we don't like many drugs, but in pediatric hypertension, sometimes we have to use them. When we want to choose the appropriate drug for pediatric patients with obesity and hypertension, we have to go back and look to the pathophysiology. The drugs of choice due to pathophysiology of obesity are drugs which are associated with the interaction of angiotensin, renin, aldosterone system. Sometimes we also use calcium blockers. For this group of patients, we rather avoid beta blockers and diuretics due to its not very good action for insulin resistant and obese patients. And as a summary, instead of summary, I would like to share with you some very important conclusions from this nice paper by Professor Wu, with which I totally agree. Body weight and blood pressure are closely correlated, and obesity-related hypertension contributes further to the clustering of cardiovascular risk factors in obesity. Because of the risk of end organ damage, timely diagnosis and initiation of treatment are important. The first-line intervention should aim for blood pressure normalization and weight reduction. I would add fat tissue reduction and inflammatory state reduction. A healthy lifestyle with daily physical activity and low sodium diet is strongly recommended. And to prevent obesity-related morbidity and mortality, the implementation of comprehensive global health programs promoting a healthy diet and physical activity are mandatory and should start as early as possible in the life. Thank you very much. And I believe that soon after this pandemic, we'll be able to see face to face. And I would like to invite you all to see my beautiful city, Krakow. And I believe that we will see soon. Thank you very much.
Thank you very much, Malgorzata. This was a fantastic lecture. I enjoyed it immensely. And one of my favorite topics is childhood hypertension, obesity and hypertension. And I think that there are several open questions. Of course, the diagnosis of hypertension is seemingly not difficult because you measure 3 times on separate days, and if they are above the cutoff value, then it's hypertension. But what is your opinion about the ambulatory blood pressure monitoring, 24-hour monitoring?
It's a great question. My personal experience with this method is quite good because I do this since at least 15 years in my obese patients. What I noticed and what is also in accordance to the literature, we observe a huge group of non-dippers in obese patients. Normally, they have quite nice values of blood pressure in our office when we just take a measurement 1, 2, 3 times. But there is a huge group of patients with non-dipping phenomenon. That is a group that I think we shall focus in the future because we have quite good papers on the cardiovascular risk in later life associated to non-dipping phenomenon. I think it's a great method, and I think we should force implementation of this method to the guidelines, at least for patients with obesity. We have quite good recommendations for this method for patients, for example, with type 1 diabetes. It's recommended to be as a method of choice to diagnose hypertension. I think we should also force to do it in obese patients. That's my opinion. I don't know if you agree.
Yeah, I think that it is very important to exclude the white coat hypertension and the non-dipping phenomenon. Yes, that's very interesting. At least according to our investigation, 30% roughly of obese patients belong to the non-dipping group.
I agree.
However, this non-dipping phenomenon is mainly characteristic to secondary hypertension, but probably the consequences of obesity on the our nervous system changes parasympathetic and sympathetic nervous system, and that's the explanation that this phenomenon exists in so frequent among obese. And now I would like to ask the audience or who stimulate the other panelists to ask questions. This is, and yes, another question that might be interesting, that how many % of your patient can be treated or improve the blood pressure where you simply by traditional treatment, diet, physical activity, weight reduction, and how many person needs pharmacological treatment?
It's a difficult question. I don't have firm data. I have not analyzed that, but my personal experience is that I think that about 1/3, maybe 20% of our patients, especially those who do not respond to our lifestyle intervention, have to be treated with drugs. You know, we have a lot of patients with obesity, most of them, especially young children, quite good response to lifestyle intervention. But we have also patients coming to my clinic from nephrology clinic who were sent by pediatrician first due to arterial hypertension, not due to obesity. And that is the group sometimes with presentation of end organ damage at the beginning, at the moment of diagnosis. For those people, we need to start a drug. But I have also quite nice experience. Many of those people, after implementation of lifestyle intervention, may stop treatment with drugs, or we can reduce the dose of amount of drugs. I don't know whether you agree, but I observe such cases.
Yes, this is very important, and mainly after adolescence, so after puberty, if they reduce body weight, then you can stop medication. And this is very important, I think. So thank you very much for being with us, and thank you very much for this excellent lecture. And I thank, of course, all panelists who devoted time and energy to participate in this webinar. And of course, I thank all those who connected and participated in the webinar. It was very difficult for us because we had to compete with the European Congress on Obesity, which is going on, or was going on yesterday and is going on today and tomorrow. So thank you very much again, and probably Malina wants to add something.
Thank you, Dénes. Just as a conclusion, I want to remind our participants that they can find a lot of interesting material on our website, such as our e-models, our e-book, and of course we have other webinars that will be announced soon on our website as well. And I would like also to let you know that the registration for the 30th Congress of ECOG taking place in November has started, and that you can also already submit an abstract if you'd like. It might interest a few participants here. That's all on my side. Dénes, I would like to thank you all for being here. And if there's no question incoming and no other comments, I think we can end this session here today. Thank you very much.
Thank you.
Thank you.
Thank you very much.
Organizing.
Thank
So
you.
the
Bye-bye.
organizing team did a great job. So Milena, thank you very much.
Thank you, Milena. And thank you, Dénes. Bye-bye.
Thank you. Bye.
Bye. Thank you.